Hi, everybody. Thanks for being here this evening. We're going to go ahead and start. A little bit of housekeeping. Food is in the back. You're welcome to have seconds, thirds, take it all. For people that are here, excuse me, for people who are here in person, if you can make sure that your cell phones are off, or either the volume, or not the volume, but the ring is cut off, so we won't be interrupting our panelists. And for folks that are on Zoom tonight, if you could make sure that you put your she was talking to me, I'm sorry. Put your phones on mute, as well as your tablets or your laptop, whatever you are using. We're going to use the chat for questions. Questions will be, you can put those in the chat for those who are on Zoom, and they'll be answered after our panelists are done. For folks here in person, we're going to answer, you can write down your questions, keep it in your mind, and we will answer those at the end when the panelists are done. Okay? I want to give kind of a little introduction of who folks are. We have ConnectRx. It's a program, oh, I got to put on my glasses, y'all. Can't see good. Okay, we have ConnectRx. It's a program that offers personalized, comprehensive support to Black working parents in Dane County. We're lucky to have Kim, Justine, I don't know why, baby, I want to call you Janella, and Shakita with us today. We also have Dr. Ryan McDonald, MD, of the UW OBGYN Division of Academic Specialists in the OBGYN, who has done a podcast with our department on postpartum depression and mental health. He has also worked at 20 South Park as an OBGYN for years, and my patients that I used to see loved him. We then have Dr. Katherine Sampene, MD, Associate Professor in Division of Academic Specialists in OBGYN, and is now the Vice Chair of Clinical Operations. She comes with over 10 years of experience in the OBGYN department. We then have Dr. Jackie Adams. She's the Assistant Professor in the Division of Maternal Fetal Medicine, who recently completed a Master's in Clinical Investigation through the UW Institute for Clinical and Transitional Research. She has been working in OBGYN for over 7.5 years. All right, so why don't we start with ConnectRx?
The slides are
Okay, so we're going to start with Dr. McDonald. And then we're going
I think we should start with Dr. Sampene.
And I should have remembered that. I'm sorry, y'all. Okay, so we're going to start with Dr. McDonald.
Thank you very much for that kind introduction. Hey, look, there's even a picture of me. I did not put that in there. All right, well, thanks everybody for being here in person, and for all of you who are online. I'm really grateful that you're all here. I think this is a really cool opportunity to get people together to talk about postpartum health, and it's definitely a privilege to be able to get us started. So we're going to talk about your mental health after pregnancy. And kind of the areas that I want to focus on are just an overview of kind of typical and atypical mental health after delivery. We're going to focus in on symptoms of baby blues, postpartum depression, and postpartum anxiety. We'll talk a little bit about prevention and treatment strategies, and then share some local resources. So why are we talking about this topic? First of all, what I really hope everybody takes away from this talk is that postpartum mental health is just the health of every person after delivery. Symptoms appear really at any phase during pregnancy or up to a year postpartum, but the changes that lead to anxiety, depression, baby blues can start within as little as 24 hours. It's also a very salient issue right now because over the last 5 years, a lot's happened in the world, and we are seeing anxiety and depression levels, in some cases doubling, especially in some specific communities. Women continue to experience significant stigma and difficulty accessing care and getting adequate treatment. And suicide is the #2 cause of perinatal death. It accounts for 20% of the perinatal deaths that occur in the first year after delivery. So Can't see behind me. Impacts. So the impacts, of course, are not only on the postpartum person, but also on her child and on the entire family unit. So, of course, we can get reduced bonding and reduced feeding. We can get reductions in breast milk production and difficulties with newborn growth. We also see strains on relationships. I'd be remiss if I didn't mention that a woman with postpartum depression or anxiety is a risk factor for their male partner or their partner also becoming depressed. And about 10% of our partners have postpartum depression as well. So we also see reduced ability to work, and it's important to know that there are some long-term impacts reflected here in this statistic. It is a 2 to 3 time increased rate that children of moms who suffer from depression or anxiety will experience that during their childhood. So moving on, about 4 out of 5 women will experience baby blues, and about 1 out of 5 women will experience postpartum depression. So if you do the math, that doesn't really leave anybody else, okay? So what you should take away from that is that these postpartum mood changes affect everybody, but to different degrees. So if we move forward, we're going to talk about what is baby blues. So baby blues are the mood changes that occur in the early postpartum phase, as I said, as early as 24 hours after delivery, and typically only last within the first 2 weeks or so. And they are characterized by mood fluctuations, feeling like your mood can change on the drop of a hat, or mood swings, irritability, tearfulness, impatience, frustration, sometimes some feelings of anxiety and feelings of sadness, but not to the level that they would, where you'd consider a person technically depressed or having generalized anxiety. Also, poor concentration. Next, though, is how do you know when it is actually postpartum depression? So the hallmark of depression and anxiety, which we're going to talk about next, is that the symptoms have become severe enough that they are limiting a person's ability to function. So if the mood is so depressed, for example, that a person can't get out of bed in the morning and can't, get going, cannot take care of themselves, cannot take care of their newborn, that's a pretty good indicator that this might be depression. It also has to do with kind of the duration. Depression is more likely to be something that lasts longer than 2 weeks. And that's part of why it feels so hopeless, is it doesn't feel like there's an end. Next up is a slide on postpartum anxiety. So anxiety is not just feeling concerned about the well-being of your baby and being anxious that they're going to be okay. It's debilitating. It's where you can't leave the house because you think that something bad is going to happen to your baby, or it is feeling like you need to go check on them, 20 times in the night, even though you've got a baby monitor on them and you can see they're just fine, or something like that. And some of the other symptoms are, an avoidance of doing other things that would probably be beneficial to you, going out and socializing, and getting out and doing exercise. And we can certainly see panic attacks when it's at the severe end. Anxiety occurs in also about 1 out of 5 or so women. So you can see that it is also quite common. And approximately 1 out of 12, 1 out of 10 people will have anxiety and depression symptoms at the same time. Next slide. So I talked about how all of these changes can happen really quickly in the first 24 hours or so. We can start to see mood changes. And it's important to understand that anybody can develop postpartum anxiety or depression. But there are risk factors that your providers and community members can look for to help to determine if somebody might be more likely to be experiencing these more severe mood changes. And probably the foremost thing is if a person has a personal history or a family history of mental illness prior to pregnancy. But another large driver that I wanted to indicate there is if somebody has dealt with postpartum depression in a previous pregnancy, their risk is up to 50% in their second pregnancy. We also, of course, see increased risk in people who have other confounding stress. If they are in an extraordinarily stressful home environment, or perhaps they've suffered pregnancy complications or delivery complications, those are going to increase the chances of depression or anxiety. So, how can you prevent or treat postpartum depression or anxiety? I feel like the list that I've put here is like how you treat basically every problem ever. And so if you're looking at that and you're thinking, well, that's shallow, there's actually a lot more to all of these. So adequate sleep. I have to say a little bit more about this because, who gets adequate sleep when you have a newborn? Like, that's not a thing. But we know that people who cannot, in a 24-hour period, get 4 hours of uninterrupted sleep are much more likely to develop postpartum mood dysfunction. That may seem like a lot. So how do you get there? Well, your doctors and everybody says sleep when the baby sleeps, right? That is really important. Taking every opportunity to get rest while you can will reduce the chance of anxiety and depression. Doing things like, and this is not for everybody, but I'm going to throw it out there anyways at the risk of getting myself in trouble. Considering pumping some of the time so that you can have your partner, if that is available to you, to do a nighttime feeding so that you can get a longer stretch of sleep. That's highly valuable. Or, you kind of have to work with your support people, whether it's your partner or your family or community, to figure out how are you going to get those much needed breaks so that you can get adequate sleep. I also want to say just a very little bit about those other points there too. So nutrition, super important. Of course, we want people to be eating healthfully while they are in their recovery period, while they are breastfeeding. But we know that there are specific vitamin and mineral deficiencies that it can increase your chance of postpartum depression and anxiety. One of the big ones is low iron. If you have extra bleeding, you are at increased risk of postpartum depression. So if you leave the hospital and you don't know if you're anemic, you might be a setup for trouble. Similarly, we know that that low vitamin D levels, which we all suffer from in this latitude, can be another reason for people to be more likely to get depression. And then I'm jumping ahead a little bit. This is a bit of a therapy option. There's very good studies now that omega-3, which is in things like salmon and other fatty fish, is a very effective treatment or preventative for postpartum depression as well. So social connection is critical for so many reasons, but this is a great time to make sure that you are not completely isolating yourself because that will put you at increased risk of depression. So when you get to the stage where you are seeing a provider because you're concerned about these things, typically they're going to talk to you about counseling or therapy and or medication. And we've got lots of options in both of these regards, but we know that both and in combination can be very effective for treatment, but they are not the only options. So expect that might be part of the story if you talk to a provider, but this is always tailored to individuals. Some types of therapy is really designed to kind of uncover maybe some triggers in your past that may be relevant. Some therapy is helping you to identify alternative ways of dealing with challenges when you have them. Some is really focused on working on the relationship and seeing how you and your partner are kind of navigating these new responsibilities together. So talk therapy, as we sometimes call it, is not the same for everybody, but definitely an important part of your treatment. Moving on. there's a lot of resources in our community. We are very fortunate. Foremost, I love that we're doing this because I think getting the word out is so big. There is a Dane County 24-hour crisis line that is available. There's also a national mental health hotline. Those are both staffed 24 hours a day, 7 days a week. Those are available for crisis. We also have lots of great support. PSI of Dane County is a nonprofit organization that makes patient-facing information and also puts people in touch with support groups. So this is awesome. Unity Point Meriter, where most of us are based for our labor and delivery care, also has support groups that are both virtual and in person, and has information on their website. Counseling services, of course, UW Health has a very comprehensive mental health service with both counseling services, which they call behavioral health, and their psychiatry team. Getting in can be challenging, but your obstetric providers will often serve as the bridge or can direct you to counselors who can serve as a bridge until you can get into longer-term care. For our clients who do not have private insurance, our clinic site that will cover their care for mental health is Journey Mental Health. And the last thing I put up there is I should have lumped also. It says community-based organizations, but the Access Community Health Center is also another great place for people who, maybe don't have as much resources to, seek care at like a private clinic or something. I also wanted to mention two resources that I did not put up there. Both the American College of Obstetrics and Gynecology, or ACOG, as well as the National Institute of Mental Health. So ACOG, last year, every year the president of ACOG gets to pick an initiative that they think is kind of the most important thing in women's health to focus on. And last year's president focused on perinatal mental health, which couldn't have been more timely as we were coming out of the pandemic. So there is a lot of resources on there for clinicians, for patients, for support people. So I would strongly recommend that you just Google perinatal mental health and ACOG, and you'll find lots of resources. And then the National Institute of Mental Health is a federal organization that has also a treasure trove of information about perinatal health. I mean, so much more depth on their website than what I could go into in the time we have today. So, wrapping up, I want you to hopefully have taken away from our time here that mental health is everybody's postpartum health experience. And so I also want you to know that postpartum anxiety and depression are common and treatable. It's never normal. I never want patients to tell me, like, I was feeling depressed, but I didn't call because, it's just what happens after you have a baby. Early care can rapidly reduce the difficulties that people go through and the impact that it was ultimately going to have on themselves, their families, and their babies. And I hope also that you come away from this feeling a little empowered that there's something that you personally can do when you see somebody in your family or friend circle who is pregnant. Because the way that we destroy the stigma around mental health is by having conversations like this, but moreover, by you having those conversations and asking about your person's mental health and how they're doing and checking in frequently and letting them know that this is just kind of part of the recovery that is important to check in about. Similarly, go back just 1 second. Listen actively and without judgment. When somebody is telling you about how they're struggling with their mood, many of you know this better than me, probably they just want somebody to sit and listen, and somebody who is going to say, tell me more about how you're doing and how that's affecting you. They're not looking for somebody to solve the problem for them, okay? So be that good listener. And lastly, please share these resources with anybody that you think they would be valuable. So I'll be happy to take some Q&A when we have a break.
Okay, my name is Katherine Sampene, and I am going to be talking with you today about family planning after pregnancy. This topic is one of many that are near and dear to my heart as a general OBGYN. And one of the reasons it's become an area of interest for me is that as a practice, we identified it as an area for improvement for doctors and providers of obstetric care. And so in our practice currently, we are working through some strategies to try to optimize the way that we counsel patients and families about their options. And so I'm excited to get to share a little bit of our updated strategies for counseling and to ultimately hear some from you all later on. So first, why is family planning important? So when we think about the timing of pregnancies and risks associated with it, we know from research that spacing out pregnancies is beneficial. Some of that sounds pretty intuitive to allow the body to heal and give yourself that time and space to enjoy the child at hand. But we also know that when children are very closely spaced, that there are increased risks of an early baby or a smaller baby in the subsequent pregnancy. And so waiting at least 6 months after the birth to become pregnant again is recommended. 12 months may be more ideal, and in some cases, there's benefit to waiting up to 18 months, especially for folks who have required a cesarean section to allow full healing. Next slide. When we think about all pregnancies that occur, sometimes the statistics can be a little bit shocking. And currently the number bounces around, but about 42% of pregnancies are unintended. That doesn't necessarily mean that the couple doesn't want the baby ultimately, but that functionally was a surprise. Now was not the time that they had in mind for that pregnancy. And as we consider the health of families, having some control and ideas about what comes next in life can be very important for that family unit. One very common question related to this topic is, when can sex be safe again? Sex can mean a lot of different things for different couples. But as far as vaginal insertion goes, we typically will recommend 4 to 6 weeks after any type of a birth. That can be really individualized depending on what has happened for your birth. So checking with your provider that knows you and what has transpired with your birth is also important. And ultimately, when the couple is considering resuming sex, having thought through the plans for the future and what options make the most sense for that family is important, so that we can avoid folks having the undesired or unwanted pregnancies. So one question that providers will typically ask pregnant people to think about during their pregnancy is whether they would like to become pregnant again. I have on the screen within 3 years, and the time frame is not as important. If you said 1 year or 2 years or 5 years or ever, all of those things are valid questions, but sometimes putting a little bit of a parameter around it can be a little more helpful or easier for folks to think through. And actually, any answer to that question is okay. So there's not a right or a wrong answer. Yes and no are sort of obvious answers, but it is absolutely okay and normal if you're not sure, or you're actually just okay either way. So whatever answer you have is valid, and it might change over time. That's also okay. But helping your provider to understand when you're talking in the clinic where you and or your family or partner are at that time is really helpful to guide the conversation. And some questions that would be helpful for you to think about when you're considering a future pregnancy are number one, of course, do I want more children? But when might that be? And additionally, how would you feel if you did get pregnant in X time frame? And that you might not know the answer, that's okay. But a lot of people have a gist of if that's a happy thing, a sad thing, a like shocked thing, et cetera. So you may have a gist of how that would settle with you if you found that out in a particular interval after the birth. Another thing is considering what the level of importance is for you and your family or your partner for preventing pregnancy. And this is another no wrong answer type of question, but it's helpful to communicate that to your obstetric provider. So again, they kind of know what the ground, what the lay of the land looks like for you and your family. For some folks, an element of surprise for your family is happy and exciting and the way that you want it to be. And for some families, that might be really distressing to have an element of surprise. So helping your provider to understand where you and your partner or family sit is important. And as I just mentioned, the answer that you have today or at maybe 28 weeks gestation may not be the same as at 6 weeks postpartum or 1 year postpartum, et cetera, and that's okay. It's not a failure on your part if you changed your mind or came to a different conclusion. It's okay to communicate that throughout. This is a busy slide, but one that I think is really important. And these are some priorities that some patients have. It's not an exhaustive list. So if there's something that's important to you when you're thinking about family planning, it's also okay to add to this list to your provider. But thinking through the topics on here and what sits as a high importance for you versus low versus not at all, again, is really helpful to have a fruitful conversation with your provider. So sorry, I'm gonna cough. Excuse me. So one is how you plan to feed your baby can impact recommended choices for pregnancy prevention. So communicating how you plan to feed your baby, if you've thought about that, and level of importance is good. Effectiveness may sound obvious, but how important is it to you that your method works really, really great? Or how important is something else other than just how well it works important to you and your family? Some methods will change periods, menstrual bleeding. I will just pause to share that many folks who are chest feeding, breastfeeding, pumping after a birth may not experience menstruation or periods for a while. That can also be normal, but additionally, the choice of contraceptive can change that. Side effects. Some side effects people perceive as good, some may perceive as bad. And that could be a whole talk in and of itself, so I won't perseverate there. Impact on my sex life. So some methods that folks choose may be able to be felt during sex, for example, like a vaginal ring. If that's something that bothers you or your partner, that may not be the best choice for you, but that's what kind of down the line of the impact on sex life. Ease of use. So how easy is it for you to get that method and use it? There can be, unfortunately, barriers to certain methods in getting them. Control, is it important that you be able to start and stop it on your own versus a provider has to place it or remove it? Privacy. There are certain situations where patients may not be on the same page with a partner. And if it is a need in your relationship for your partner not to have your contraceptive information, there are methods that can be discreet. past experience. So some people have tried stuff, they didn't like it, they did like it. That's helpful to know. And the timing of the start, so whether you were able to get that on board before resuming sex or not, can be important for risk. Cost and insurance coverage can be a thing. Now, while most methods are covered under insurance, or all methods are essentially covered under insurance, some folks may be at risk of losing their insurance 4 to 6 weeks or so after their birth. So knowing if that is a risk for you is important. And then for some, whether it aligns with ethical or religious beliefs could be very important. And sharing that with your doctor helps make sure that conversations align with where your wishes lie. This slide just kind of shows the breadth of options. It's not a slide I'm going to perseverate on today because each of those could be an hour-long talk on its own, and we won't do that tonight. But there are a lot of choices. So while sometimes we may be in a place where we wish we had more, these are demonstrate what we do have today, and your provider can definitely talk in depth about any of those options. I put a couple of just really common questions that don't maybe get talked about quite as much at the end here. We'll kind of chat through these and then give you some resources before I conclude. So one question that comes up is whether lactation essentially is a method of birth control or preventing pregnancy. And the answer is it can be. It depends on several things. So all of the following need to be true for it to be considered a method of birth control. So number one, babies feeding at the breast rather than pumping. It doesn't mean that pumping can't prevent pregnancy. The way that these can work in that fashion is by preventing ovulation or release of the egg. It just has not been as well studied. So we don't know as much about pumping people and that efficacy. The second is that you are feeding around the clock at least every 4 hours, meaning you got to balance all things. So if you're struggling and need more sleep and you are doing some bottle feeds, whether it's pumped or formula, et cetera, if that is a need that you need to prioritize, it will likely lower the efficacy of birth control from breastfeeding because it does require that constant stimulation of the breast to be effective. It assumes that you're not having periods. If you are getting periods in the postpartum period after your initial bleeding stops, maybe a sign that you are in fact releasing that egg and ovulating. You're a person where that's not as effective for. And then that your baby's younger than 6 months. So typically around the 6-month time frame, people may be introducing some formula, solid foods, and then natural efficacy, even if you are giving, breast milk maybe as the only source of liquid, it's less effective. So you just have to be more cautious with that after the 6-month time frame. And ultimately, breastfeeding is about 90% effective-ish if all those things are followed. Last brief topic is sterilization. This is actually an extremely common method that's chosen by folks in our country. There are methods for sterilizing both men and women. There are a lot of different words used to describe that. So for men, vasectomy is the typical term, but you may hear like snipped or kind of other colloquial terms from that standpoint. And for tubal sterilization for women, that has a lot of different names: tubes tied, sterilization, et cetera. So salpingectomy is the removal of the fallopian tube, which is a very common method in current times. But knowing that different people call that different things. And we always, as providers, just want to balance your need for pregnancy prevention with your other health factors and risk of regret. So one big thing is that understanding that these procedural methods are considered permanent or not reversible. And ultimately, some insurances do require a person to sign paperwork 30 to 180 days ahead of time. So knowing if your insurance type falls into that category is really important to allow you access to that care should you want it. That's something that you'd sign with your doctor. And lastly, I have a resource page here. There's a QR code there, which if you were to open that, it will lead you to that top page there, which is on Meritor's website. And if you scroll down, you'll find that next thing called Family Planning After Pregnancy. And there is both English and Spanish resources there. The worksheet goes through a similar amount of information as we covered today about assessing your priorities and what's important to you. And then the one that's labeled Common Questions After Pregnancy is more of a traditional handout type information that has commonly asked questions as well as pretty detailed information about each of those methods. So it's a good place to start if you're trying to dig into what's right for you.
Hi, everybody. I'm Jackie Adams, and I am a maternal fetal medicine doctor at UW. If you aren't familiar with MFM, it's essentially I did the same training that Dr. McDonald and Dr. Sampene did, and then did some extra training in high-risk pregnancy and medical conditions. So we're really excited you're all here. And really what I'm hoping to talk about, it seems like a little bit of a mishmash, but I promise it's going to make sense once I start going through it, is how your pregnancy and your postpartum period can sort of be a window into your future health. So I think for many, many years, we did sort of a poor job thinking about pregnancy and what it means for long-term health outcomes. And we've really sort of re-looked at this over the last years. And we know that the physiology of pregnancy can have long-term implications. And that holds true whether you have health problems going into pregnancy or whether you don't have health problems going into pregnancy. So I could talk all day about this because literally my whole job is just to sit and talk with people and how their health might affect their pregnancy and their baby and what that recovery period might look like. But what we really want to focus on today is just some common things that happen in pregnancy that might need long-term follow-up and what that can look like for people. So the first thing I'm going to talk about is gestational diabetes. So I know we've got a smaller room here, but does anybody know what gestational diabetes is or has ever met anybody with gestational diabetes? Yeah? Great. So a little bit, people have definitely heard of it before. Gestational diabetes is very similar to the diabetes that you hear from family members or that people have experienced that are not pregnant. But essentially what it boils down to is when you're pregnant, the hormones released from the placenta and from the pregnancy actually sort of overcome that insulin or that resistance that you have in your body, and it makes your blood sugar high. Now, what we know is that gestational diabetes is limited to pregnancy, but what we've gotten a lot smarter about over the last few years is that it can be a key predictor of the development of diabetes. If you think about it, it makes sense, right? Like if only about allegedly 20% of people end up with gestational diabetes, why do they get it but somebody else doesn't? And if you've met somebody with gestational diabetes, they don't all look the same, right? It can happen to people that are of normal weight, that run marathons, things like that. And so there's something about the insulin resistance that your body has or that pregnancy causes that can put you at risk of having gestational diabetes, and we can't always predict who that is. But what we do know, and what we've done kind of a poor job talking to people about, is that it is a risk factor for having diabetes later in life. So a lot of times people get treated for gestational diabetes in their pregnancy. They might need pills that they take every day or need shots of insulin, but most of them are going to do just fine. Once that placenta is delivered and they go home, they probably don't need their medications anymore. A lot of times we actually just follow them up about 6 weeks to 12 weeks after they deliver. But what we do know now is that if someone has gestational diabetes, they're 7 times more likely to develop type 2 diabetes in the next 10 years. And that adds up to about, depending on the study you look at, around 15 to 50% of people will end up with a diagnosis of diabetes in the future. So that's a much larger number than I think we've traditionally talked about. And so it's also a risk factor for other things. So it's not only a risk factor for having diabetes in the future, it's also a risk factor for having things like cardiovascular disease. And so if you look at whole numbers, if you line up all the people that end up with cardiovascular disease, it's actually an equal risk factor to smoking, which is kind of hard to believe when you think about this thing that we think is traditionally self-limited to pregnancy. But we know that for whatever reason, having gestational diabetes can have long-term impacts on our health. So, and also on the impact, or have long-term impacts on babies too. So, like I said, a lot of times when people have gestational diabetes, they're looked at very closely in their pregnancy. They're checking their blood sugars 4 times a day. They're going in for a lot of frequent doctor's office appointments, taking medications or insulin, and then that follow-up really kind of falls off after delivery. But I think what's most important to understand is that we do need to keep track of folks that have gestational diabetes because they do need that long-term follow-up. And that can look like a lot of different things. The number one thing I see in my office, and I'm sure you guys would agree, is getting back for that glucose test when you have a newborn is just the worst. I wish there were an easier way to do it, but you've got to coordinate it with the lab. You need to set off time for an hour to drink the yucky orange drink and get your blood drawn. And so it's very easily missed. And, that's a problem in and of itself, because that means we're missing some people that maybe have diabetes that's developed in the meantime. And then a very common scenario that we see is that those folks come back in another pregnancy, they never had follow-up, and then they have pre-existing diabetes. And so, we've really missed a window of opportunity there to help care for them, to help manage their health, to really optimize their diabetes care. And so one thing that we really try to emphasize with our patients is the importance of that follow-up and making sure that they have that done. So the other thing that we do is obviously after that 4 to 12 week period in the immediate postpartum period, just making sure that you're following up with a primary care doctor and getting diabetes screening. The good news is you don't have to keep drinking the yucky orange drink every year. That's only what we do in pregnancy and what we do in the postpartum period. After that, we kind of go back to the traditional diabetes screening, which is usually a fasting glucose or a hemoglobin A1C. And those are just blood tests that you can get done in the office. So this is one thing that, can really have a huge impact, not only on your health when you're recovering after having a baby, but for future pregnancies and for your future health. So another area that we see a lot of are folks with gestational hypertension and preeclampsia. So again, I know it's a small room, but has everybody at least heard of preeclampsia or heard of high blood pressure in pregnancy? So I think this has gotten a lot more media attention because it is so serious and because many of us at some point in our lives have met someone that had high blood pressure when they were pregnant. And so we know a little bit more about it. And again, this is a very specific type of high blood pressure that happens only during pregnancy. I hate to blame the placenta for everything, but we do think it has something to do with the hormones that are made by the placenta. Also, just an exaggeration of the normal cardiovascular and kidney changes that happen in pregnancy that lead to this. So we traditionally think that, again, once baby is delivered and that placenta is delivered, that this goes away. But we're getting more and more evidence that maybe that's just not true. So one thing we know for sure is that the volume or the extra blood and the extra fluid you make during pregnancy, we used to think that really started to go away and sort of those major changes happen about three days to a week after you delivered. We now know that for people with high blood pressure, that kind of lasts a lot longer than we thought that it did. And so I have people all the time that have never had a high blood pressure in their life. They get preeclampsia and they have to go home on blood pressure medicines. And they always ask me how long are they going to need to be on it. And the answer is we just don't know. Sometimes it's not very long. Sometimes as soon as they start to lose all that extra fluid and they start to what we call diurese or get rid of the extra blood and fluid that they've made to protect their bodies from pregnancy, it gets better. Sometimes it can take 6 to 8 weeks. Sometimes it can even take longer. And there's a small proportion of people where their blood pressure just never really goes back to normal. Now, we could talk all day about the physiology behind that. Are those people just, were they already going to get high blood pressure and pregnancy was the thing that unmasked it? Or is it truly that they just had so many physiological changes to their kidneys and otherwise their cardiovascular system that it never went away? But what we do know is that if you have one of these hypertensive disorders of pregnancy, you're about 5 times more likely to have high blood pressure later in your life. And again, this is a big risk factor. This is on the level of like smoking or of gaining excess weight or having another cardiovascular condition as far as your risk for high blood pressure. You're also about 2 times more likely to have heart disease or cardiovascular disease, and about twice as likely to have a stroke. So again, these are not, I don't say this to scare people when they have high blood pressure, but I think that we really need to pay more attention to long-term health, because sometimes the diagnosis of high blood pressure or preeclampsia is the tip-off that we need, that this person might need closer monitoring after they go home. So I put this slide up here. This is actually from the Preeclampsia Foundation website. If you ever get a chance, you can just search Preeclampsia Foundation, but I did put the QR code there. It's maybe one of the best done patient websites I've ever seen. So I always go here because I learn something new every time, and also because they have fantastic graphics. So one of the things that this is just 10 tips for your long-term health, but like I talked about with gestational diabetes, there is follow-up that you need for your long-term health if you have preeclampsia or gestational hypertension. And what that looks like is, like we said, this seems so simple, but trying to live an active lifestyle. If you're smoking, making sure that you're cutting down on smoking, focusing on your nutrition. Another thing that we don't often talk about is that you need to follow up with your primary care doctor a little bit more frequently. So most people that have had high blood pressure in pregnancy really should get seen about every year for a check-in with their PCP to make sure their blood pressure looks okay, to make sure that they haven't sort of made that leap into having high blood pressure. And also just to make sure that if they do have high blood pressure and they need medications, that they get started on those. So again, it's really, really hard when you're at home and you have a newborn and getting into the office to get all these follow-ups, but making sure that we don't miss folks that are going to have high blood pressure before they get pregnant again can really change outcomes. And one thing I didn't specifically mention is that having high blood pressure that isn't followed up on can actually affect your kidneys in the long term. And so if that's the case, then we want to make sure that we've got you optimized and that your kidneys are healthy and your blood pressure and your heart are healthy before you have another pregnancy. So again, if you ever want to look more about this, the preeclampsia, there's many good websites, but the Preeclampsia Foundation has great ones. And I've even had patients pull it up and bring it to their primary care doctors and say, no, my OBGYN told me I need to get my blood pressure checked and I need to have these labs done. So it's definitely got good handouts on there for you too. The last thing I wanted to talk about, and this isn't specifically a maternal problem per se, but it is risk of preterm birth. So having a preterm birth does put you, specifically a preterm birth, that's what we call spontaneous. So I think we've all known people that have had a preterm birth because mom was sick or because there was something going on with the baby or for another reason. But specifically going into labor early on your own with no sort of identifiable reason is a risk factor for that to happen again. And depending on the numbers that you look at and how early you were when you delivered, this risk of it happening again can be about 35 to 40%. And so I say this because one thing that I think we as healthcare providers can really work on is making sure when we have somebody that has a preterm birth, we talk to them right after that birth. So one of my jobs as an MFM is to do consults for people that have had an adverse pregnancy outcome like a preterm birth. And I always tell people the best information I'm ever going to get about what happened with their delivery is what the doctor at that time wrote. So if they wrote, I think this person had bleeding for this reason, or I think this was spontaneous, or I think this was because they had high blood pressure or something, I'm never going to get better information than that because I wasn't there. I didn't see the delivery. I don't know what happened. I don't know the circumstances of what brought them into the hospital. And so many times it's hard for the person that experienced this to really remember a lot of fine details because they were obviously in distress. They were going through a life-altering event. And so I always try and go and talk to that person while they're in the hospital and make sure we really document what happened because we want to have that information for a future pregnancy. So some things there are treatments for to help prevent a preterm birth. Some things, unfortunately, there are not. And so having that information from the prior delivery is really important. It's also helpful, and something I think that we could really do better is saying what we want that person to do before they become pregnant again. So, like Dr. Sampene said, we ideally space pregnancies between 12 to 18 months because that does help reduce the risk of having another preterm birth. There are some risk factors for preterm birth, not a ton, but things like smoking can be a risk factor. If your uterus has an abnormal shape or contour, like if you've ever heard someone say that their uterus is shaped like a heart or that they have a line in the middle of their uterus called a septum, things like that can be a risk factor for preterm birth. Some people have no idea why they had a preterm birth, and so then it's really important when they go home that I go investigate that, right? I need to get an ultrasound to see what their uterus looks like, go through their medical records, make sure there's nothing there, make sure that they didn't have high blood pressure or another identifiable risk factor. And so, it may seem silly to say that you need, having a preterm birth involves a lot of long-term follow-up, but it's really important that when this happens, because it can happen again in a future pregnancy, and because it can have implications for the mom going forward, that we really do a good job going through what happened in that pregnancy, documenting it, and that way we kind of have a plan going forward in the future pregnancy. And that plan can look like a lot of different things. It could be as simple as just getting an ultrasound, like I said. Sometimes we'll do things called cervical links, which is a look at the cervix throughout the pregnancy. And there may even be additional surgeries or things that the person may need. So, I think, is that my last one, or do I have one more? Okay, so I'm going to wrap up there, and I'm happy to talk more about this.
All right, good evening, everyone. My name is Kim Ashford. I'm the Community Health Worker Supervisor for the ConnectRx Wisconsin program. My team and I are here to just give you a little bit more information about our program, but it does exist right here in our community, and we've been serving our community since 2022. Okay. So to really just kick us off, we often get the question, what is ConnectRx? Who do we serve? So the ConnectRx program works to eliminate Black and white birth disparities. We also have a focus on reducing Black infant mortality rates, because we know that from data that Black infants are 2 to 3 times more likely to die before their first birthday than white babies. And so we support our moms up to 1 year postpartum. This work cannot be done without a collaborative approach. So we have multiple partners that are at the table with us that helps really drive this work forward. Just to list a few of those partners, we work very closely with MMSD, Public Health Madison, Dane County. We also work with the Foundation for Black Women's Wellness for doula support. And of course, we work with all the local healthcare systems, including Access, which is federally funded. Our program really works to provide comprehensive support to Black birthing persons in Dane County. So our support consists of a community health worker and a doula. The doula is at no cost to I say patient because I work with patients, but is at no cost to the client or the families that we're supporting. So if that's something that they want, that's something that we work really hard to get them connected with. And again, the Foundation for Black Women's Wellness really provides that support for our families. We offer one-on-one case management support that's really tailored to meet the needs of the individual families in which we're supporting. So it looks very different for each family. We support the family as a whole. So we don't just focus on mom and baby, we focus on all the other children and dad as a very close and important piece of mom being healthy and having good well-being, because we know that if mom is healthy and thriving, then the household is healthy and thriving. So our focus is really on 5 key social determinants of health. So we focus very heavily on housing instability, food insecurity, transportation needs, stress, and financial hardship. Our goal is really to improve birth outcomes by really connecting our clients with vital community-based resources to really start addressing those social needs so that mom can focus on her health and baby's well-being throughout the pregnancy. Next slide. So we really wanted you to understand the difference between a doula versus a community health worker and how we work collectively to really support the patient as a whole. So as a community health worker, our main job is really essentially addressing health disparities, really promoting that health equity within the healthcare systems and improving access to healthcare services. And we have a hyper focus on underserved communities. Our CHWs are advocates, we're educators, we're connectors, who helps individuals and families get connected to resources right there in their community. We really work to improve health outcomes by addressing barriers such as language, cultural differences, and lack of access to care and health literacy.
Just following up a little bit more about the advocacy and the connection that we do in our work, just because of past historical events and personal experiences, there is a mistrust in the healthcare system. There's also some implicit bias between not only the patients, but their providers as well. And part of our job is to mend that relationship because it is a human right to have equitable healthcare. Shakita, you could speak a little bit more about what you do as a doula. Hi, yes.
Hi, yes, my name is Shakita. Hi, yes, my name is Shakita, and I am a doula. I'm actually newly certified postpartum doula, yay. And heavy emphasis on that part. And actually my own birthing journey is what got me into the work. And as it's up here on top is emotional support and encouragement during labor, but not just during labor, it's also after. And as Justine has stated, there's so much trauma that has already been experienced in this space, and vulnerability can be scary, and it is debilitating, and that comes from trauma and stored trauma. And a lot of times as a doula in this space, we're holding space for these families, and visibility matters. And that way, mom and their partner and who's ever involved can make informed decisions for themselves and their families. Yeah. Next slide, please.
All right, so there are some eligibility requirements for our program. First, you must identify as African, Black, or African American. You must have a positive pregnancy test, and you must screen for one or more of the social determinants of health. This could be financial strain, transportation issues, food insecurity, housing insecurity. Also, we are a referral-based program, so you must be receiving OB care in Dane County. Like Kim said earlier, it could be with any of the health partners, so that concludes Access, UW Health, Merit, or SSM Health. Again, you don't have to live in Dane County, you just have to receive care in Dane County.
Next slide.
Me again. Okay, so up here in the corner we have here asking for help is okay. And as I stated before, asking for help can be scary because that's a whole nother level of intimacy, and that includes being vulnerable. And that in itself is scary, especially if you've had different experiences in these spaces. And self-care isn't linear. It's a mindset, a way of being that involves being present, whole. It's a journey acknowledging that you deserve to take care of yourself. And making space to do so. It's also a process which might look like taking small steps and doable changes over time. It's not, sometimes it can seem, appear as an indulgence, but it's a necessity. By a show of hands, how many of us practice self-care in here? Consistently. Online too, people online. Ask yourself that question. Okay, we're being real. A lot of us don't, and for some of us, if it's never been modeled or mirrored, what does that look like? So that starts back, starting with the foundations. I'm worthy of this. I deserve this. And I'll pass one. Does anybody want to add? Because I can go.
I just want to say we attended a maternal health policy group not too long ago, and one of the questions that was asked was how many people would have wanted somebody to check in on them after a baby. And that brings up just the brilliant thought that, you know, once baby's here, everyone forgets about mom, for more or less. They always think about baby, how cute baby is, like Kim said before, but nobody really worries about mom anymore. And so part of at least my job and what I've done in some of my caseloads is ask mom how she's doing, and then giving her space, because everyone's gonna be like, oh, I'm fine, oh, I'm okay. But then asking how she's really doing. And then I know Shakita has up there that learn how to say no, but also in our program, we do see that a postpartum period is a time where a lot of our patients go silent or go ghost. And silence is also an answer. It's an answer that we don't really like to deal with, but we do deal with it quite a lot. But it's part of our job to still support the patient even when there is that silence. So whether it's a text message or an email or something, because a lot of our patients don't have a support system, so we may be the only ones there. And we just still try to show as much support as possible, especially during that last part of the pregnancy.
I just wanted to add, and this is just really from personal experience, I think postpartum depression isn't talked about enough. I think for us, we've been normalizing that mental health is a medical condition, that our patients don't always recognize it as that for cultural reasons, and that it is okay, like they all said, to ask for help, but also to talk to your doctor about different medication options that might be appropriate for you. And so we're always focused on health management, so well-being overall and not just during that 1 year postpartum phase. And so we're heavy on just like the self-care, but one of the things that I really just wanted to drive home is that mom guilt is real. I experienced a lot of mom guilt just because my milk production wasn't very good after I had baby. And there's nothing worse than like not being able to produce food for your baby and being exhausted all at once. And so like when I work with my moms, I really talk to them about it's okay not to be okay. And it's okay to talk about those things, but it's also okay. Like I used to be against giving my baby formula because I'm like, no, like I should be able to provide like food for my baby. And one of the best advice that somebody gave me, and I feel like it took a really long time to set in, is a fed baby is a happy baby. It doesn't matter if they're getting it by formula. It doesn't matter if they're getting it by chest or breast. Like as long as baby is fed and happy, like that's all that matters. And just like separation anxiety, right? Like a lot of us have a lot of issues with like, I'm going back to work. What does that mean? Will I be able to pump and produce enough milk? Will I be able like is my baby okay at daycare? And so one of the things that we really coach our patients on is like finding daycare providers that are willing to accommodate whatever your needs are. If that's a video of your baby throughout the day just so that you have peace of mind at work. If that's working for an employer that has a space that's designated just for you to do lactation, or photos, right? Or a camera that you can tap into to just know that your baby is doing okay, to kind of help with some of that separation anxiety. And then another thing that I really drive home for my clients is it's okay for baby to cry. If baby is crying, baby is okay. And so if you need to take a moment to step away so that you can regroup yourself, that you can show up and be the best version of yourself as a parent, that is okay. And so those are just a few things that I just wanted to share that we really just try to really drive home with our families, because mom well-being does matter. And I think a lot of times as parents, we prioritize our children over our own well-being. And so really that self-care piece is huge, because in order for your family to be good, like I said earlier, you have to be well.
Is it okay if I drive us home? Okay. When a woman prioritizes her well-being, as Kim stated, that not only impacts her, but impacts her entire family. And what we want is secure bonds with our families, with their moms and babies, because those are core memories. So that's what we want. And we did extend this invitation to our patients. So if there's any moms that are online that are listening, your experiences are important and your healing journey is significant. Acknowledge your pain and trauma is valid. Remember that your story holds beauty. There is hope for healing and joy beyond the struggles. You deserve to be the healthiest version of yourself, and your children deserve that too. Thank you.
Wow, guys, that was kind of powerful. You go, girl. And if we don't take nothing else from this tonight, I can say from every single one of the panelists, it's about taking care of yourself and looking at the warning signs and looking what's happening with your body, because things can change. Adrian from UW Health, Adrian Jones, has a few questions that came in before while people was registering. And if you have any questions for people in the room, I'm going to give her the mic and she's going to give it to you to ask them.
Hi, everybody. All right, we can start with one of the questions that came in online. And the question is how to handle postpartum with baby and toddler as a stay-at-home mom.
I'm going to take a shot at this, but this is totally mom advice and not physician advice. So I had a 3-year-old and a newborn when I was a trainee. We call that the dark time in my house. And I think the key for my family and what's really important is just, we talked about this so much, but social support. So I was very lucky that I had a partner that was much better at raising children than I was, and we're being totally honest. And we tag teamed everything: bedtime, feeding, meal prep. There was a really great interview that Brene Brown did that she said, like, come home and tell your partner every day, like, how much gas you have in the tank. And I think we really did that. Like, I've got 40% in the tank today, and he luckily would say, well, I'm just going to have to fake 60 then. And so I think that's really important. And whoever your social support is, if it's a family member, if it's a neighbor, if it's someone in your community that you can lean on, there's really no other way around it, because you've got to get kids to bed, you've got to do that. And most importantly, you have to be able to sleep, and you have to be able to have that mental reserve to be there and be present for your toddler while still trying to navigate that newborn. So you're a little bit wiser, you have a little bit more experience, but you're also, as my husband said, playing zone defense instead of man on man. So that's my advice.
I tell people two things: a very firm nighttime routine. Bedtime is bedtime. And the one thing that I definitely took away from our first birth experience, that I did differently with the second one, was to have my freezer fully stocked with casseroles and frozen soup and stuff to make all of those meal times much easier after our second child came around.
I think the only thing that I would add is getting your toddler involved. Like, it's okay for them to help, so make a game out of it. So we used to, my girls are 2.5 years apart, so I brought a gift for her from the baby because I wanted her to like the baby and because she was strong on take the baby back to the hospital, and that was not an option. And so we made a game out of just like her being able to help. Like, okay, you're gonna sit next to mommy, and you're gonna hold the baby, and you're gonna feed the baby, and just like redirecting her, but also getting her involved, really just kind of help with that transition of like also being there and present for the toddler and showing them that you still love them, even though a lot of your attention is a lot more focused on baby because they need you a little bit more than the toddler might need you at the time. So I'd say get baby involved, get the toddler involved.
Nice. Yeah, my kids, well, one is off somewhere else, are also 2.5 years apart, and schedule is super important. I prided myself when I happened to get them both on the same afternoon nap. That was chef kiss out of everything else. And, you know, fun fact, full story moment is Dr. McDonald actually delivered my oldest. So she doesn't know that, but yeah, you all do. All right, is there a question in the room? Oh, okay.
This question was directed at Dr. McDonald, but I think we'll split it up between our ConnectRx friends and Dr. McDonald. A lot of the focus of postpartum mental health is often on after it's already started to become a problem. Post-birth and depression and anxiety are kind of making themselves known. Is there room in improving care for people beforehand, kind of building some of those skills, building some of those tools, connecting to resources before mental health becomes a concern or before baby is even born? How do you advise people to start building some of the supports they might need after their pregnancy is over?
I think that's a great question, and I think that our slide that showed, kind of prevention and treatment strategies really does get at that. So much of what you build up as you are getting towards the end of your pregnancy, in terms of your support network and your self-care strategies, are going to, kind of then follow into your postpartum recovery. I always tell people that like all of the foundation that you build in the second and third trimester when you are feeling relatively well is what's going to help, set the groundwork for your postpartum and your recovery time. So yeah, take a look back at that, at those slides, and definitely thinking about it early is important. I try to, during that last month of pregnancy, really tell all of my pregnant clients and their partners that they are entering a time of unprecedented turmoil. And to feel like they are going a little bit crazy is the normal, but they need to know when it's more than that and to seek help.
All right. Another question that came in online is, what non-hormonal birth control is recommended after birth and while breastfeeding?
So as far as non-hormonal birth controls, those don't have any effect on breastfeeding. So you can choose those methods freely. There are a variety. So starting from less likely to prevent pregnancy to most likely to prevent pregnancy would be things like condoms, spermicide, diaphragms. There are non-hormonal forms of intrauterine devices, or IUDs. It is also called a copper IUD, or the brand in the US is called Paragard. That's highly effective. And then there's procedural methods, which would be the permanent options for birth control that folks will call sterilization, or those lots of other names that we mentioned.
Any questions in the room?
We'll do some more from the chat while folks in the room kind of think through what they'd like to ask about. So we had a couple more come in. This one I think may be aimed for Dr. Adams. Does the risk for type 2 diabetes increase with the number of subsequent pregnancies with gestational diabetes? So how does that curve work?
Yeah, Okay, sorry, I don't know why this keeps faking me out. You would think I've used a microphone before, but the answer is yes, and that's for a couple of different reasons. So one, if you have gestational diabetes and more than one pregnancy, it's an increased risk factor. Oh, it's straight. Okay, sounds good.
I thought it sounded funny. So I said the answer is kind of yes for a couple different reasons. So if you have gestational diabetes and more than one pregnancy, it's a risk factor. But there's also going to be a certain subset of people that, like I said, have probably developed either pre-diabetes or type 2 diabetes in the interim, and for whatever reason didn't come for their subsequent glucose testing, or weren't able to follow up, or maybe they had a close interval pregnancy and they just never made it in. And so it's being called gestational diabetes because it's not being identified until pregnancy, when really that person's either at risk of developing diabetes or already has it in the first place. So yes, in sort of two different mechanisms.
Maybe no, it's kind of working. I get it. This one is faking out. Okay, Rob hasn't said anything, so I think we're fine. Are there different postpartum considerations for people who are expecting twins? How do you recommend folks who are expecting more than one baby in one go get ready?
I have no good answers. I think that your support network and your strategies for maintaining sleep are doubly important, because obviously the demands on your time and your energy are going to feel more than twice as much.
I can just say it if you want. There's a resource that I got from another physician, OBGYN mom, as a very reasonable thing. So I won't claim to be the expert on postpartum moms with twins. But there's a book called When You're Expecting Twins, Triplets, or Quads, the 4th edition, Proven Guidelines for a Healthy Multiple Pregnancy. So there's at least a little tidbit there, but I won't pretend to be the how to raise twins expert.
From my experience, everybody navigates that in their own way and the best that they can, and hopefully has lots of support.
All right, we have another one online. Can anyone elaborate on the use of sertraline or Zoloft during pregnancy and when baby is born?
Yeah, both of those medicines are in the class of that we call selective serotonin reuptake inhibitors, or SSRIs. This is a type of medicine that affects a chemical in your brain that, when it is kind of kept in the space between nerve cells, it causes feelings of kind of well-being and kind of mellows people out. So effectively, these medicines will kind of blunt some of the lower moods, but also blunt maybe some of those more anxious and aroused moods that people can feel too. So those are very common medicines that are used to treat both postpartum depression and anxiety. Especially Zoloft or sertraline is the one that is most studied and has countless studies about the safety in pregnancy. It's not associated with birth defects, and in general, while working with your healthcare providers, together, you're going to make a plan for whether or not medication therapy is appropriate for you, in combination possibly with counseling or talk therapy, like we mentioned. But for many people, if they have a pre-existing depression or anxiety going into pregnancy, staying on these medicines can be safe and very effective. And I will just say two more things. If you are on those medicines before pregnancy, I would strongly encourage you to speak with your provider before taking yourself off of those medicines when you find out you are pregnant, because that can actually be harmful and people can have a remission of their mental health concerns. And there are some newer medicines, one in particular that is available for people who have more severe depression symptoms that works by other mechanisms. So we do have medication strategies beyond kind of the tried and true Zoloft or sertraline that most people are familiar with.
What's the name of the medication?
Zuranolone. It's called Zuranolone.
Alarming health signs, symptoms, watch for from hospitals for moms.
Alarming health signs, symptoms to watch for once home from the hospital.
That's a really great question and super important for folks, both all parts of the family to know, so that you can help look out for your friends and family too. So there's lots of different things that could go wrong after the birth. From the standpoint of some of the things that Dr. Adams was talking about, if you may not have high blood pressure diagnosed in your birth and it could still happen afterwards, some of those symptoms could be headache, visual changes, pain in your abdomen, especially if it's up higher than where your birth pain was. Those are reasons that you should reach out to your provider right away and get checked out. Other things, folks are more commonly prone to getting clots in their blood vessels after a birth compared to when you're not pregnant or postpartum. So looking out for signs of that would be one of your legs is big, swollen, red, painful, or if the clot were in your chest, it could be pain with breathing, pain in your chest, feeling short of breath. And if it was a clot in your brain, that would be things like you're not talking, moving, kind of doing your normal things normally, the same kind of stroke symptoms that you may be familiar with from kind of public health alerts for older folks. And then the other big one would be infection. So your classic fever, but also if you think that the discharge that's coming vaginally looks foul or like pus, yellow, green, you have pain that seems like not what you were expecting after your birth. Those are all reasons to truly listen to your body, get checked out right away. That can be starting with a call to your doctor, but if something seems more scary than that, just going straight to the ER is always appropriate.
No, I agree with everything she says, and I think the ConnectRx folks will agree with me too. If at any point you say to yourself something just isn't right, nothing makes the hair stand on the back of my neck more than those words coming from a woman that is pregnant or just had a baby. If it doesn't feel right, if it's not like your previous pregnancies, if your family members are worried about you or something like that, we'd rather see you 100 times and make sure everything's okay than have you stay at home and not get checked out. So, there's the very specific things, but then I think there is something really to be said about just trusting your intuition. And if it doesn't seem right, then tell someone.
Another online question. Thank you so much to our online audience for being very, very curious tonight. What advice do you have for moms who are returning to work after their maternity leave? Specifically, what kind of accommodations should moms feel empowered to ask for from their employers as they navigate through their postpartum time?
I think when you think about going back to work, some accommodations that make sense is asking your employer, is there a safe space for you to pump? And how much time is allowed for you to pump, and where is it located based on where you're stationed at, especially if you work in a large hospital. Just because that time that you travel to get to that destination in your workplace is going to take away from your time and your ability to pump. So those are one of the questions that I always make sure that my clients ask. Another thing is just making sure you have safe and reliable childcare. It helps reduce a lot of stress that you feel when you're going back to work. I think, I talked a little bit about just the separation anxiety that already comes with going back to work, especially if I think the reality is some of us get 6 weeks and some of us get up to 12 weeks. And so just kind of doing a self-check about where you are at and not feeling rushed to go back to work if that is an option for you.
Everything what Kim said, but one thing that's most important is have these conversations with your employers early, so you have a plan early, and know your rights.
I will say someone amazing in the chat also just shared 2 links, what you should know about the Pregnant Workers Fairness Act from the Equal Opportunity Employment Conditions. So we'll make sure that link goes out to everyone who registered, as well as a very crucial resource.
Thank you, Yolanda. Yes, we all know who that is. Thank you, Yolanda. I was just going to say, Yolanda, actually, who is online, shared a link today about equal opportunity employment, and there is a section on pregnancy about that, so feel free to look on that and see what your rights are during pregnancy, while you're working, and after pregnancy as well.
Early conversations, advocate for yourself, speak up.
That's good self-care.
That's right. There you go. Tie in.
We have another online question. They just keep coming, and we've got a few minutes left. What does periods of extreme stress in life have? What kind of impact can periods of extreme stress in life have during pregnancy, especially if stress, anxiety, or depression are left untreated?
That's a really great question and a really hard one to answer, and a common question, because so many of us have stressful events that occur during pregnancy. We also know that pregnancy is a time where we have increased risks of things like intimate partner violence. We run into all of these situations that we've been talking about that can be stressful, like financial hardship or housing instability, among others. And we know that when people have prolonged chronic stress, that rises stress hormones in our bodies, and that can lead to damage to the very tiny tissues in all of our organs. And we see in some studies that this leads to also some increased chances of behavioral problems in our kiddos, and long-term health effects. The challenge is knowing exactly how much and what type and what the exact outcome for somebody is going to be. The science really is not able to do that. What I would say is, if you are having a stressful situation in your life, but you have the self-care mechanisms, or you have kind of I hate the word coping skills, that makes it sound like it's like your fault if you don't have them. But if you have strategies for dealing with stress that allow you to have some de-stressed moments, then stress is not necessarily bad. If stress helps you rise up and deal with the problem that you're having, and you can get back to a good place, great. But if you are constantly under a degree of stress that is raising your stress hormones and you can't get a break from that, and it's happening for weeks or months, then I do think that that is a risk factor for both your long-term health and your baby's.
All right, any last questions in the room before we wrap up? Yes, great, yay.
Hi, I'm going to have a large age gap between my children. My daughter will be 13 4 days after my due date. So I was just wondering if there's more chance of postpartum depression with my age being 38 already as to when I had her at 24.
That just means you know what you're doing better. I don't know of any evidence that says that as parents are older or there is a large gap between children, that is specifically a risk factor for postpartum mood concerns. So no, I would not expect that's like need to be more on the lookout for trouble. I think that's awesome.
Is there any more questions from the audience? Okay. Somebody say something? Okay. Well, I want to thank all our panelists for being here this evening. It's really been wonderful. And all the in-person folks as well as our folks on virtual. Resources as well as the PowerPoints, we will be emailing those out to folks who are interested in having that information once we wrap all this stuff up. So you guys have a good night. Take care. Bye.